All right, can you guys hear me in the back there? Okay, so we're not getting too late of a start. Thank you for your adaptability. So if you're not supposed to be in cardiology, DNAS 305, you need to figure out where you need to be, but that's us here. So I'm Dr. Birch. You can usually get me on my email address. I check my emails once a day, or in the morning. So if you email me Friday afternoon, I'll get it Monday morning. So just keep that in mind. The time they gave me for office hours is Friday afternoon. So if you need to meet, that'll probably be good. Otherwise, you have to find me on clinic or in the lab someplace. But Friday afternoon, I should be in my office. My office number is 1173, so just down the hall here. That should cover most of that. Okay, this is the way we're going to be assessing the course. So pretty standard. Definitely want to get above 70, just for everybody involved. The points, half of your points are going to be from your exams, so the midterm and the final. It'll be just about daily quizzes, probably not every class period, but enough that it's easier to say that there'll always be a quiz at the beginning of class. It'll be over the readings, so I'm going to assign readings to I'll put them in the module for that class period. So the quizzes will be over those assigned readings. We're going to drop, or we are going to drop. I'm going to drop your lowest score. So if you have an emergency, can't make it, or whatever, it's okay. We're going to drop that lowest score. If you have 2 emergencies, you're out of luck. So take your emergencies carefully. There'll be a couple of assignments that are going to be graded separately. At the end of the quarter, I'm going to give you guys some different cases, and I'll have you write up a case report on that, regarding that patient's caries risk and treatment that you're planning to do and everything like that. But we're going to go over that in a lot more, or we're going to spend the whole quarter going over that, so you'll know what to do when we get there. We're going to have a lab. I've requested a lab, but after getting our classroom taken from us, I'm not sure if we're going to actually have a lab room to work in, but I'll work on that. But anyway, after the lab, you will get to write a report on what you did. So that will be worth 9%, and then you get 1% for filling out the survey and get the report. Okay, so that will be our point distribution. So what are we going to be doing? So don't get confused, this is very similar to the class that the dental students get. So there will be the odd 705 that pops up, just because the material is the same. So DNS 705, 305, it's the same stuff. But we're going to talk about dental caries. And so where do we find it? How does it happen? We're going to talk about the chemistry and the biology. There's a bunch of different theories on caries. We're going to talk about how you identify it, how you classify it, and most importantly, what we do to treat it or prevent it. You might be asking yourself, well, I'm a hygienist. What the heck am I doing in a caries class? You're looking at teeth, and your patients are going to ask you about it. And Lots of times, you guys remember the Peanuts cartoons when the kids are in the classroom and the teacher's talking and it's just wah wah. That's the way patients listen to the dentist. Lots of times the dentist will be talking and so it happens to me. I'm talking to my patients, I'm just putting it all into my patient presentation, and then they go over to the hygienist and I hear them and they say, so what did he say? So you guys are going to be the translators. So you need to understand what caries is. And you need to be able to recognize it when you see it. Because lots of times when the patient sits down with the dentist for the first time, their teeth are all covered in stuff and the dentist can't see anything at all. And they're going to miss teeth that have caries on them. So you may not legally be able to diagnose caries, but you sure as heck can see it and point it out to the dentist. My daughter, when she was just a toddler, which was a long time, but anyway, she loved sitting on my lap and reading my dental journals with me, mostly because they had the pretty histological slides and their purples and pinks and but the 2-year-old would point at a tooth and say, that tooth is sick. So if a 2-year-old can do it, my hygienist can do it also. So and you're just a huge help. A huge second pair of eyes is just super important. That's a very informative slide. So we're going to be talking about changes, because not all. This isn't the same way that I was taught caries when I was in dental school. A lot of what I was taught was there's a hole, clean it and fill it. And then there's an interesting quote that soon we're going to be doing a lot more preventative and reparative dentistry rather than surgical dentistry or filling holes. Except that this was written by G.V. Black back in the late 1800s, so a long time ago. So it's taken us a long time to make this change. But we're going to make it. At the beginning of the lectures, I'm going to try to put up lecture objectives for that lecture, and the questions I take from the lectures for the exams will be coming from these lecture objectives. But these objectives are very general, and so I'm going to be asking very specific questions. So you're going to have to know a lot about dental caries, other than just the plain old definition. You're going to need to know and understand about it. And so, but this will give you a framework of what to look at when you're studying. But today we're going to talk a lot about different definitions today, just so that, because people throw around all sorts of words when they're talking about caries, and if you're not sure exactly what they're talking about, or if you both have different understandings of what the word might mean, then it can be really confusing. We're going to talk about a bunch of different theories on caries. They're just theories. It's evolving, and probably in a few years it's going to be different again. But we're going to be kind of looking at what our understanding was with caries in the beginning and where we are now, and those kind of things. Hi. We just took over this classroom.
Oh, did you get kicked out?
Yeah, radiology is
Going to.
Radiology is in our room. And they're from 8 to 12.
Interesting. Okay, let me know.
Almost what I said.
Okay, yeah, I'm sure. I think Shirley's class is coming up too.
Yeah, I don't know.
No. Yeah. I'll go check.
Yeah, anyway, we'll work it out after lecture.
Don't leave this room.
Okay, I got. Okay, so we're gonna see where our understanding of caries was and where it is now, and kind of maybe directions we might be moving. We're going to talk about DMFT scores, DMFS scores. So you guys have a little heads up on the dental students. You might know. Anybody know what DMFT, DMFS is? No? Okay. Well, we'll talk a lot about it. And then we're going to talk about some different caries classification systems. So you'll need to understand all of those as well. Let's just start out with a basic definition. Because if you ask your patient when they come into the office, what is dental caries, they're like, lots of patients don't even know. They're like, caries? And I thought I had a cavity. And they're like, yeah, well, it's cavities. But patients often think of caries as just a hole in the tooth. But what I want you guys to understand is caries is a disease. It's not a hole in the tooth. It's a disease. And the problem is it's a multifactorial disease, and there's all sorts of different risk factors that affect it. There's protective factors that will affect the progression of the disease. But this definition that I first saw was in 2007. But understanding caries as a disease is a very important paradigm shift. So whenever we say caries, I want you guys to think disease. Okay. So caries is just a fancy way of saying rot. Caries comes from Latin root word for rot or rotten. So when we're talking about dental caries, we're just talking about rotten teeth. So people were aware of this for a long time. 5000 BC, there's a reference in the Sumerian text about dental worms eating away the tooth. And similar things have been found in India and Japan and China. So people have been aware of caries for a long time. Back in the 1700s, Pierre Fauchard was one of the first ones to kind of reject the idea that there were worms that were eating away the teeth, and he was one of the first people to talk about how sugar is detrimental to the teeth. When Leeuwenhoek was inventing the microscope, he was able to see microorganisms under the microscope, microorganisms that he had taken from the plaque, the dental plaque. He was able to see those in the microscope. So he was one of the first people to suggest that microorganisms were possibly involved in dental caries. And then in the late 1800s, Miller came up with the idea that the parasite or the bacteria were causing a shift in the environment, making it more acidic, and this in turn caused the decay. So this has been called the non-specific plaque hypothesis, and it was just that bacteria are bad, they cause acid and makes holes in the teeth. Around the same time, Dr. Albert Schatz was looking at it in a slightly different way, and he said that the tooth decay was not from the acidic erosion of the teeth, but it was from the demineralization was caused by chelating agents that dissolve the enamel minerals, and that there was enzymatic breakdown of the enamel proteins that was causing the holes in the teeth. So this was a bit of an issue because on one hand you have one guy saying that it's an enzymatic process, a chelation process, and on the other you got this guy saying it's an bacterial acid attack that's causing the decay. So in the 1940s, the International Association of Dental Research, they had a meeting, and they, instead of looking at the evidence and deciding, which is the stronger theory, they just took a popular vote and decided that that Miller's acidogenic non-specific plaque hypothesis would be the accepted theory of caries, and that that's where all the research was going to go. So it was kind of an interesting way to figure out what is happening. But this was reported in the Journal of Dental Research in 2003. But it was just a popular vote, so it was. But that's the way it went. And so, do you guys remember Koh's postulates from biology? Not so much. This is a while ago. Shorter for you than me. But Koh's postulates say that you can define a disease by finding the specific organism that is always associated with the given disease. You find that organism, you isolate it, and then you take that isolated organism and reinfect it in a healthy host, and then you can reproduce the disease. If you can do all four of those things, then you have a disease. So Fitzgerald and Keyes were able to show that strep mutans and lactobacilli were the infectious agents for dental caries. And they were able to demonstrate that this could be transmitted from a sick host to a healthy individual. So this was really a big step in our understanding of caries. So when they were able to do that, it kind of changed the theory of caries. So it went from a non-specific plaque hypothesis where all bacteria are bad to a specific plaque hypothesis, namely that strep mutans and lactobacilli were the causative agents for dental caries. But it wasn't quite as easy as that, because they were able to get rid of the lactobacillus and the strep mutans, and people were still getting decay. So they came up with another plaque hypothesis. This is the ecological plaque hypothesis, and this says that you'll only get the disease when there's a shift in the homeostatic balance in the oral environment, and so that that shift in the balance in the environment will cause a change in the microflora, which alters the pH, which favors the pathogenic bacteria, which causes the disease. So the ecological plaque hypothesis linked the bacteria and the environment together. So not all the people that I'm talking to you about are dead. Philip Marsh came up with the extended ecological plaque hypothesis. I was able to meet him at a conference a couple of years ago. He's a really interesting guy. He's come up with this hypothesis that has influenced dentists around the world, and he was telling us that he's so nervous when he gets up in front of dentists because he's not a dentist and he doesn't feel like he knows what he's talking about. And it's just really interesting. Oh, Philip Marsh is the guy in the middle. That's Dr. Brian Novi in the front there, who's taking the selfie. But the extended ecological plaque hypothesis just takes it one step farther, and it says that in the presence of low pH, even if you don't have any of the pathogenic bacteria like the lactobacillus and the strep mutans, normally non-pathogenic bacteria like actinomyces they can adapt to produce acid. So they adapt to the low pH environment to produce acid, which further destabilizes the environment and makes it more acidic, which allows the pathogenic bacteria, the main pathogenic bacteria, to come in and predominate. So this is an important understanding, because even if if you're not infected with the lactobacillus or strep mutans, if the environment in your mouth changes a little bit, then the normal non-pathogenic bacteria will adapt to live in that environment, which will then shift the environment to a pathological state. So even though the chelation dental fluid transport theory was voted out of popularity, people were still working on it a little bit. There was a couple people here at Loma Linda, Dr. Steinman and Dr. Leonora, who put a lot of work into the dental fluid transport theory, and they were able to show that there's how does this go back? That there's dental lymph, and the dental lymph flows from the pulp of the tooth through the dentinal tubules out through the enamel to the outside of the tooth. And this dental lymph was protective, had a number of interesting properties. It's controlled by the parotid gland. So the parotid gland is a dual function gland. It has an exocrine function that produces the saliva. And it has an endocrine function also that produces the parotid hormone. And this parotid hormone is what controls the dental lymph. This dental lymph flows from the pulp through the dentin and out of the enamel. So you have the physical flow of the fluid that's keeping the outside of the tooth clean. The dental lymph has a pH of 7.4, which is very basic, so it acts as a buffer against any of the acids that the bacteria might produce from breaking down the sugar. So it protects the tooth. This dental fluid flow can be interrupted by many different things. High sugar intake will interrupt it, stress will interrupt it, poor nutrition will interrupt it, lack of exercise will interrupt it, other pharmacological agents will interrupt it other than sugar as well. You can turn that fluid flow back on with antioxidants. So Steinman and Leonora used the carbamyl phosphate to turn it back on, but other antioxidants will turn that fluid flow back on as well. So they were able to do a number of different experiments that. So one interesting experiment they did was they put a dye into the stomach of a rat, and within 2 hours they were able to see the dye in the pulp chamber, and then into the dentinal tubules, and even coming out the side of the tooth through the enamel. And so then they were able to, by either using sugar or whatever, they were able to stop the flow. They would even reverse the flow. So some really interesting studies. There was a study that studied 2 different populations. One of them, most of the community drank green tea, so a very strong antioxidant. And there was another village nearby who had virtually identical diet, other than that they didn't have green tea in their diet, and they were able to show a difference in the caries rate between the two different populations. So there's some pretty strong evidence that the dental lymph and antioxidants play an important role in caries. We still haven't gotten past the vote, and so there are two separate theories right now, but probably the truth is somewhere in the middle. Probably both things are true, but we just don't understand it well enough yet. Okay, so this is you'll notice on this summary slide that there's no names or dates or pictures or anything like that, so I don't want you guys to remember Philip Marsh or Miller or Steinman and Leonora. I just want you to know what the different theories are. Okay, so you'll need to understand this summary page pretty good. This will help kind of understand where we are in our understanding of caries right now, and hopefully it'll help you understand that we don't know what we're talking about and that we still need there's a lot left to learn. So epidemiology. Caries is a very widespread disease. It's found throughout the population, throughout the different ages, different sexes. Everybody gets decay. Caries prevalence is reported as either decayed missing filled teeth or decayed missing filled surfaces. And most of the time, this is based on caries that have visibly penetrated the dental enamel junction. So most of these caries prevalence reports they're reporting advanced caries only. So they're probably underreporting the actual incidence of caries in the population. Occasionally, the epidemiologists will use radiographs to help with the diagnosis, but mostly it's just done by a visual method. You guys have already been looking at teeth, so you understand that sometimes the sealant looks kind of like a composite, and it's kind of so. If the epidemiologist confuses a sealant with a filling, then they've overestimated the incidence of caries for that patient. And if the epidemiologist isn't careful and doesn't ask the proper questions, like why don't you have a tooth right there? It might have been lost because they played hockey and they ate a hockey puck. And so it has nothing to do with caries. Or it may have been lost due to periodontal disease, so it has nothing to do with caries. So the caries prevalence reports are estimates. And so there's something that's going to underestimate the prevalence of caries and some things that are going to underestimate the prevalence of caries. And caries as a disease in the population has changed over time. A long time ago, the estimated prevalence of caries was somewhere between 1.5% and 12%, which is kind of a big range. But they're just guessing based on skulls and different things like that. But back then, occlusal caries was relatively uncommon. The attrition, so the wear of the teeth, usually wore the teeth out before the caries did. So the root caries was the predominant form of caries. So I spent a few years in Africa, And I was able to see something similar to that in the extreme north of the country where I was at. There was not a lot of processed foods. It was mostly grain that they would get the chaff and the stuff out of the grain by throwing it up in the air and letting the wind blow it away. So there was always little surprises in your porridge or bread or whatever they made out of it, like rocks and sand, and it was on the edge of the Sahara, so there was plenty of sand. But everybody had flat teeth, and I didn't see very much decay in the occlusal surfaces at all. But in the roots of the teeth, they definitely had. That's where they would get the decay. So it was similar. They didn't, back in the 1500s, they didn't have a lot of processed foods, and so the coarseness of the food just wore away the tooth before the caries could get to it. But in the 1600s, we started getting more refined foods, and the caries prevalence jumped. So from maybe a high of 12%, it went up of 25%. And this was definitely correlated to the introduction of refined foods and sugars into the diet. And it was a new pattern of caries. This is when we started seeing caries in the pits and fissures of the teeth, and later on in the proximal surfaces of the teeth. And by the end of the 1800s, all of the developed countries had this type of decay. Then in the 1900s, it just kept going up. The DMFS scores in all age groups in the U.S. was 38. But the caries was seen primarily in high-income countries. So the countries that had easy access to refined foods and sugars, they are the ones that got the decay. In the developing countries where they didn't have access to the processed foods and sugars, there wasn't as much decay. In the late 1900s, with the introduction of fluoride into the water and into the toothpaste, we saw a decrease in the DMFS scores. Most of these improvements were in young children. And again, it made a difference where you lived. So the countries that had a high gross national product or had access to the fluoridated water, fluoridated toothpaste, they saw a reduction in the DMFS scores. But countries that didn't have access to this new technology, they didn't have they didn't see that reduction. The problem is the people that were caught in the middle. So the developing countries that were kind of making it, they had access to refined foods and sugars, but not so much access to the fluoridated water, and so they showed the highest DMFS scores at that time. Okay, so DMFS scores, it's kind of a no-brainer, but DMFS scores increase with age because you never, well, except for deciduous teeth, you never, once you get a filling or a decay in the tooth, it never gets better. The DMFS index is cumulative, so decay becomes filled, and filled becomes maybe missing over time, so it just keeps adding up. So it's a cumulative score. So the DMFS scores, remember the difference between the DMFS and the DMFT. So decayed missing filled surfaces counts the surfaces of the teeth. Decayed missing filled teeth just counts the teeth that are affected by the caries. So a missing tooth, when you're talking about a DMFS index, counts as 5 surfaces. Whereas if you're missing a tooth and you're doing a DMFT score, it would only count as 1. So if you had a 3 surface filling, it would count as a 3 in a DMFS study, and it would only count as 1 if you were doing a DMFT epidemiological study. So just remember that difference between the DMFS and the DMFT scores. Some people have thinks that maybe females have generally higher DMFS scores. Back when they did these studies, women didn't work as much, so they had more time to go to the dentist, so they got more fillings. So maybe that's why they thought, but anymore you can't say that males are less susceptible or women are more susceptible to decay. It's pretty much even across the board. People have wondered if race plays a role in dental caries, and not really. Race probably doesn't play a huge role in dental caries. Socioeconomic status, however, plays a huge role in caries. If you don't have the money to take care of your teeth, to brush your teeth, buy fluoridated toothpaste, your incidence of caries goes up. If you've never been taught, when you're in a room full of dentists and hygienists, it seems kind of funny that nobody ever tells people how to brush their teeth. But lots of people just don't know how to brush their teeth. They don't know why they should brush their teeth, and lots of people's dental IQ just haven't gotten the information, so they just don't know that, and that definitely plays a huge role in the caries incidence and the prevalence of caries. So socioeconomic status plays a big role in the distribution of caries. So very little evidence that race or ethnicity plays a role. Definitely socioeconomic status plays a huge role, and that has to do with education, income, occupation. So DMFS scores are inversely related to the socioeconomic status. So as your socioeconomic status goes down, your DMFS scores go up. If you're generalizing. And then there's always the patient that tells you, doctor, my family just has weak teeth. And then they might not be totally wrong. Do you have a question?
Is it a good correlation? Is it a good correlation to assume that low socioeconomic status also leads to more refined foods, or
Probably.
is that why?
Yeah, more. Actually, I don't like. So epidemiological studies are helpful, except that they tend to generalize, and so as soon as you start generalizing, you're gonna miss some people. But yes, in general, you're correct. This is helpful in giving you a general understanding, but each patient that comes into your chair is an individual, and you don't know where they are until you start talking to them and getting to know them. So I wouldn't use this to decide that your patient is high caries risk just by looking at them. You probably need to talk to them. But it helps us figure out what are risks and what are protective factors. But yeah, so when I was a young or a fresh out of school dentist, I used to laugh and think that when my patients told me that their family just had bad teeth, I was like, yeah, you need to brush your teeth. But there's probably a little bit of truth to that because the caries that the family has may be due to bacterial transmission. And it's been shown that kids, so babies, have the same dental flora as their primary caregiver, whether that's the mom or the grandma or the babysitter. They've been able to isolate the same strains of bacteria from the primary caregiver and the baby. So there is bacterial transmission. One study went further. They compared oral flora in preschoolers, and all the kids in the preschool had similar bacteria also. So that's a little bit scary. But yeah, bacterial transmission is a real thing. And then where do kids learn their dietary habits, or where do kids learn their behavior habits, if not from their family, right? So they eat the same food that their family eats. They brush their teeth, or they don't brush their teeth the very same way that their family does. So family habits will create a familial pattern as well. And then genetics plays a role, because how your tooth is made up, what kind of saliva you make. All those things are based on genetics. So there are familiar patterns to the teeth. So now when my patients tell me, well, I have decay just because my family has soft teeth, I tell them, well, yeah, that's probably true. So we just know what we have to work on, and it gives us something to focus on. So, but try to give them the power to do something about their teeth. All right, so we were talking about a paradigm shift and about how I want you guys to think of caries as a disease and not as a hole in the tooth. But it's really important because when you're talking with colleagues, when you're talking with patients, if you're using terms that one person thinks means one thing and another person thinks means another thing, it's just going to be really confusing. So we're going to go over a few definitions here. So again, caries is a disease. It's a multifactorial disease, has many different risk factors, many different protective factors, but caries is a disease. What lots of people think of as caries would be the caries lesion. So the hole in the tooth would be what you would call the caries lesion. And the caries lesion is just a symptom of caries, the disease. And this caries lesion begins it has to begin somewhere, but it begins very small. And it just begins with the initial demineralization of the enamel. So the prevalence of caries is probably much higher than is reported, because to see this initial lesion, you have to look at a clean, dry tooth. You have to have good light. You can't just be holding a flashlight and counting teeth. You need good light to be able to see this initial demineralization of the enamel. But understanding that this dental lesion starts really small and being able to identify it shifts the intervention strategies from being a predominantly surgical strategy to being more of a preventative strategy. So if you can identify these carious lesions when they're just small, then you can remineralize them. So you don't have to do fillings on on all the cavities that a person has. So, back in 2010, Dr. Fontana wrote in the Dental Clinics of North America that modern dental caries management needs to focus on the detection of earlier stages of the disease. And by being able to diagnose the disease earlier, then these lesions can be treated and we can avoid having to do more surgical type interventions on these diseases. So diagnosing dental caries needs to be an objective determination of whether there's a lesion or not. And once you've detected it, you need to determine how severe it is. So how far has it progressed? And probably most importantly, for these initial lesions is determining whether or not the lesion is active or progressing, or if it's has been arrested or remineralized. Because if you have a lesion that has been remineralized or arrested, then there's definitely no further need of treatment for that tooth. So traditionally, when we talked about caries management, we were talking about cleaning up all the holes in the teeth and putting really beautiful tooth-like restorations in them. And we didn't really look at what was causing the disease itself. We were only treating the symptoms of the disease. So there's limited evidence that restorative care is effective in preventing caries. There was a study done that actually looked at, they had one population group where all they did was they cleaned out the decay and put fillings in. They compared that to a group where they addressed the causes of the decay, the caries. And it's not terribly surprising, but the people that just got fillings came back with more decay underneath their fillings. The people where they addressed the causes of the disease, their caries rate went down. So just doing fillings or crowns or whatever doesn't stop the disease. You have to address the underlying causes of the disease. If you've been a dentist long enough, or if you've been around dental patients long enough, you'll find that a little filling grows up to be a big filling, which grows up to be a crown, which grows up to be a root canal, and finally you end up losing the teeth. So it's a progressive thing unless you address the underlying cause of the disease. So if you understand caries as a hole in the tooth, and you miss the whole causative problem of the caries. If you understand caries as a disease, then you can understand how to stop the progression of the disease. So the new old approach to caries is to use non-destructive, risk-based caries management using the best scientific evidence available. So just figuring out what is causing the disease and taking measures to stop it. So Dr. Fontana again, this is our responsibility as dental health professionals, educators, researchers, is to use the best evidence available in the detection, assessment, management, and monitoring of caries lesions. So that's where we're headed for. So if I keep repeating myself, you might think that it is important, but dental caries is a multifactorial disease. You might see that at some point later on. The dental caries lesion is just a clinical manifestation of the disease. So the the caries lesion is not the caries, it's just a manifestation of it's just a symptom of the disease. Dental fluorosis. So fluoride's a good thing, a little bit is good, a lot must be better, right? Not so much. Dental fluorosis happens when you get too much fluoride, and it actually causes a hypomineralization of the tooth. So teeth that have too much fluoride have less mineral in them. Dental fluorosis is only happens with developing teeth. So if you give me too much fluoride, I might have other problems, but I'm not going to get dental fluorosis. It only happens when teeth are developing. Okay, so if you're talking about central incisors, it's just within the first 15 to 30 months. But it is, and it's systemic fluoride. You can't, because it's the developing tooth, putting fluoride varnish on teeth that are already erupted, they're no longer developing, so you're not going to cause fluorosis by using too much fluoride varnish or gel or brushing your teeth too much. You can't cause fluorosis that way. If you have a patient whose teeth are still developing and they haven't learned how to spit very well yet, so if you're talking about a 2-year-old or something, and they, instead of spitting out the toothpaste, they swallow all that yummy tasting toothpaste, then yeah, that can cause fluorosis. So it's just the systemic fluoride that will cause fluorosis. Okay, so on your computers, you should be able to see this a little bit better. The light in here is not as good, but the dental caries lesion. So usually these are initial lesions that we're looking at right here. It's hard to say whether this is just staining in here or if that's the initial demineralization of the tooth. But on this one here, where you have this little kind of matte white halo around the little dark spot, that would be a small caries lesion that's developing there. I can't see on that. I have to look at my computer. Here in this central groove on your computers, you can probably see a similar little matte white halo around that central groove there. So that might be an early caries lesion as well. When I was in school, they taught us to, if you saw something that looked questionable, like this one here, you're like, is this stain or is this decay? They taught us to take our Explorer and poke it in there to see if it was sticky. We try not to do that anymore, because if you have an initial caries lesion, so the minerals have been taken out of it, but that organic matrix is still intact, you take your Explorer and shove it in there, and all you do is you just break down that matrix. So if there wasn't a lesion there before, there is now. So you just made one yourself. The other thing, they've been able to show that if you did use your Explorer and probed a caries lesion, they were able to show that you could, just like in your microbiology class where you took that little wire loop and you scooped up some bacteria and then inoculated it on a new agar plate, you do the same thing with your Explorer. You can pick up the bacteria and transmit it to a new healthy site. So we try to stay away from poking our Explorers into a caries lesion anymore. Now, the way we recommend that you use an Explorer is you drag it across the surface of the tooth to determine if the surface is hard and intact or if it's starting to break down. Because if you have a healthy tooth and you drag your Explorer across it, it's going to slide like glass. If you have a carious lesion and you drag your Explorer across it, it's kind of like dragging it across a piece of leather or against a. You guys aren't old enough to know what chalkboards are, but just a little bit rough, and it just gives you a little bit of resistance, so it doesn't slide smoothly. So that's the way we recommend using an Explorer now. All right, here's some pictures of fluorosis. So fluorosis comes in all sorts of varieties. But you can have a really mild fluorosis where you just have a little bit of banding on the teeth that's a little bit whiter than the surrounding tooth. Or you can have really severe, this is kind of dark, but this is mostly dentin here. And the little bits of enamel that are left just kind of flick off. So if you take a Cavitron to the severely fluorosed teeth, you can just knock off all the little bits of enamel that are left. So you have to be really, or if you take your Explorer, you can just flick all those off. So you have to be really careful with the severely fluorosed teeth. Okay, dental erosion. So dental erosion is just the wearing away of the tooth by some other process other than the dental caries. So it can be from acids from the stomach. It can be acids from the food. Has anybody seen a patient who likes to suck on lemons? Yeah, it makes a really, it erodes the teeth. So that would be a form of dental erosion. Just as an aside, when you see a patient that, so if caries is an acidic problem, why do teeth that have caries in them look different than the teeth that from people who suck on lemons? Because they look really different from each other. The dental caries is soft and mushy. People who suck on lemons, the teeth are eroded, but it's hard and shiny. It's a totally different process. So it should make you wonder a little bit. But anyway.
Do you know why?
Yeah, I know that we don't know.
Oh.
Yeah. But I think it has to do with probably the dental fluid transport theory probably has more to do with caries than a lot of people would think. So there's probably, so it may be initiated by the cariogenic process, but there's also a chelation effect that's breaking down the organic matrix of the tooth at the same time. So I think it's probably a combination of those theories, but we just need more evidence. So we have the clinical evidence that we don't know exactly what's going on, but we don't have the research yet to back it up. So acidic erosion. There are other types of erosion, like abrasion, where the teeth are worn away by bobby pins or toothbrushes or something is wearing away the teeth. There's attrition where the teeth are wearing away as well. So we'll look at all these different ones. This is an example of dental erosion, acidic erosion. And this is what you see in there can be a number of different things that cause this, but this could be caused by acid reflux that's just going up and getting on these occlusal surfaces of the teeth. So all you see is a little bit of enamel that goes around the tooth, and all of this is dentin, exposed dentin in here. So acid reflux could do this, GERD. People who are throwing up a lot will get this a lot. So your patients, your bulimic patients will present like this. Sometimes if you get people who are trying to control their weight for competitions like wrestling or bodybuilding, or so they're trying to cut a lot of weight, and if they do it by throwing up, you'll get this kind of presentation also. I had a little, how old was he? He was about 4 years old, and he showed up like this, and I was like, what? So I was talking to his mom and asking her, does he get sick a lot? And he was like, no. And so I was running out of questions to ask. Finally, I just asked her, what does he like to eat, or what does he like to drink? And this little boy, he liked apple juice, but he didn't want to swallow it. So he would just take the apple juice and hold it in his mouth, and this is the way he looked. Well, he had a mixed dentition, or he had primary dentition, but he just eroded all his teeth just by holding the. Yeah, so patients do the weirdest things. Okay, abrasion. Abrasion is a form of erosion. It's just the wearing away of the dental tissues by some sort of mechanical device. People who chew on their nails, chew on bobby pins, people who brush with the hard toothbrushes, improper use of dental floss. So we tell our patients to make the floss into a C shape and go up and down. I saw a picture of a case where the patient used the dental floss but put it down in there and then sawed it back and forth. And they'd actually cut a groove into the tooth just like a saw. So yeah, use your floss wisely. But that's abrasion. Demastication is the wearing away of the teeth just by eating food. So my patients that I saw in the north part of Cameroon, where their teeth were worn away flat, that would be the demastication. Attrition is the wearing away of the teeth just from tooth to tooth contact. So clenching, grinding, that would be attrition. And it's, usually they're just worn. If I smile, you'll be able to see a nice example of attrition. Abfractions is a kind of a different type of erosion, but it's a wedge shape, so it's a very distinctive wedge-shaped lesion that occurs at the cemento-enamel junction, and usually it's caused by poor occlusion. So the forces that are being applied to the tooth are being applied at a point where the teeth can't support it. So that force is being transmitted through the enamel and causing the little enamel crystals to fracture off at the cemento-enamel junction. So mostly you see it when the teeth are coming together edge to edge or something like that. So here's a picture of dental attrition. You can see how the teeth are worn flat across canine to canine. So it really affects the patient's aesthetics. You go from where you can't see the teeth at all, or from before, they had a nice pretty tooth line below their lip, and then they go to kind of an empty smile. So treating this, first you have to figure out what's causing the attrition before you restore these people to a normal. Otherwise, if you put veneers or crowns on these teeth, they'll just knock them off because they're still doing the same behaviors. Okay, this is a dental abfraction, so you can see that it's a very angular. Go back. It's a very angular lesion, and it occurs right at the CEJ. So this would be, there's probably some sort of, when the patient goes into their chewing motion, they're hitting their teeth in an abnormal way. Okay, so So caries is a dynamic process. So and it can go forwards and backwards. So you get, when you're talking about the initial carious lesion, it can progress and become more severe, or it can remineralize and become less severe. So the caries process is made up of demineralization, so the loss of minerals from the teeth, and it also involves remineralization, so incorporating the minerals back into the teeth. And in a healthy individual, this process occurs all the time. Right now, your teeth are demineralizing and remineralizing, and that's a normal part of the oral process. The problem comes when you get more demineralization than you have remineralization. That's when the caries lesion progresses. Okay, so arrest. That seems like a pretty funny thing, but when we're talking about arresting caries, we're talking about stopping the demineralization process and remineralizing the tooth. So an arrested caries lesion is one that has it's no longer, that balance is no longer skewed towards the demineralization side, it's back into the remineralization side. Okay. So the caries lesion, so for the longest time, we didn't think a tooth had a problem until there was a hole in it. But now, by being able to diagnose the caries lesion earlier, or define the caries lesion earlier, we can find these earlier so that we can treat them without having to cut them out. But the caries lesion is just a detectable change in the tooth structure that results from it's just from the biofilm tooth interactions. It's the first clinical manifestation of the caries process, and it's just where the demineralization of the tooth is outpacing the remineralization of the tooth. When you're talking about the caries lesion extent, you're talking about how deep does the caries go towards the pulp of the tooth. So how close is that lesion to the pulp of the tooth? Okay. When you're talking about the severity of the caries lesion, you're just talking about how far has that caries lesion progressed. So is it just at the initial demineralization stage? Has it gotten through the enamel? Has the organic matrix of the tooth started to break down already? So this is what we're talking about when we're talking about the caries lesion severity. So a non-cavitated lesion is one where the physical structure of the tooth is still intact, and it's just that the minerals have been taken out of that part of the tooth. If you have a cavitated lesion, it means that the organic matrix has broken down and you have an actual hole in the tooth. Right, so non-cavitated lesions, so the tooth appears whole, but the lesion has begun to demineralize already. So the non-cavitated lesion is just the initial demineralization of the tooth. And these early non-cavitated lesions will often show up as a white spot. So when you're looking at a tooth, you'll notice one spot that is more matte white color than the surrounding shiny white of the rest of the tooth. This would be a white spot lesion. So the white spot lesion, you can't tell just by looking at it if it's an active progressing lesion or if it's remineralized. So this is where using your Explorer is very helpful. It's a white spot lesion that is active. When you drag your Explorer across it, it's going to feel a little bit rough and bumpy. If it's a remineralized white spot lesion, it's going to feel smooth, like the rest of the tooth, like glass when you drag your Explorer across it. A brown spot lesion, lots of times when a dentist sees a brown spot, they're like, oh, that's decay, it has to come out. But you can have a brown spot lesion that is remineralized as well. And so the only thing wrong with it is that it's brown. Lots of times the white spot lesion will pick up stains from what the patient eats or just from the local environment, and it'll stain the tooth brown. And that by itself doesn't mean that the decay is active or inactive. It's just a color. So again, you have to check it with your Explorer to see whether or not that initial lesion is active or not. Okay, some people will talk about a microcavitation, and that would just be the initial breakdown of the enamel. So it'd be just where the enamel has been demineralized, and now it's starting to crumble away a little bit. But these are very small cavities, and they're limited to the enamel, so there's no dentin involved at this point. Okay. Again, with a cavity or a cavitated lesion, this is where the actual structure of the tooth is broken down, and you have what your patients, or when my daughter was little, but she could diagnose as decay. It's the obvious hole in the tooth. When people were thinking of caries as a hole in the tooth, they used to say that this patient is caries free, but it's probably an obsolete term, because you can't say a patient doesn't have the disease unless you're going to check bacterial levels to see if they have the infection. So you can have caries free used to mean that there was just no cavities in the patient. So now a patient can have, they may not have any carious lesions, but they could still have caries the disease. It's just that they have enough protective factors that they're keeping the disease under control. So it would just be that the disease is controlled. Again, active caries is kind of an obsolete term. It used to be used for patients that had holes in their teeth. They would say they have active caries. Now we talk about caries activity more to when we're talking about where the tooth is in the demineralization, remineralization process. So if the tooth is having more more demineralization than remineralization, then we would say that carious lesion is active. If it has more remineralization and less demineralization, then we'd say that carious lesion is inactive. Okay, but the carious lesion activity just describes where the lesion is in the process of remineralization or demineralization. So an active caries lesion would be a caries lesion where over time there's a net mineral loss. And an arrested or an inactive caries lesion would be a lesion where over time you have a net mineral gain within that lesion. Okay. Sometimes with an arrested lesion you can see a scar, but it doesn't mean that there's, I haven't had a surgery on my arm, so I have a great big scar on it, but it doesn't mean my arm is healing now. It's already healed and it's intact, and for the most part works like it used to. Same thing with an inactive caries lesion. You might be able to see the evidence that there was caries there in the past, but the tooth itself is healthy at this point. So don't do a filling on it. Okay, caries lesion regression. Again, it's just the net gain of calcified minerals. Remineralized caries lesion is the lesion that has gone from a mineral loss to actual mineral gain. So a hidden caries lesion, or some people call it occult caries, would be a term where the lesion is so hidden caries lesion is one where to be able to diagnose caries you have to have a clean tooth. And so if you have a lesion along the gingival margin of the tooth and it's all covered up with plaque, you're not going to see it until you clean away the plaque. And so that's what some people will call the hidden caries lesion. Okay. All right, so that's the first half of the lecture. We're running a little bit behind. Do you guys have any questions? Pretty straightforward. I'd love to give you all a break, but we probably need to bust through this a little bit just so we get through it all. So we'll just continue it on. So when we talk about diagnosing the lesions, so we talked a little bit about diagnosing the lesions early, so that you can treat them early in a more of a restorative process than a surgical process. So we're going to talk a little bit about how we find and evaluate caries lesions. Normally, we use a Mirror and Explorer. The Mirror and Explorer are going to give us a limited amount of information. Basically, it's what you can see and what you can feel. So you're just so you're not going to, obviously you can't diagnose lesions that you can't see or feel when you're using a Mirror and Explorer. But you can see the size of the lesion as far as how much of the tooth is, how much of the surface of the tooth is involved. You can get an estimate of the depth if it's a cavitated lesion already. You can determine if the lesion is cavitated or not, or if it's an initial lesion. So there's about 3 types of lesions that we're talking about here. So the incipient lesions would be just the initial lesions where the tooth hasn't broken down yet. So the tooth itself is intact. You just have that initial presentation of caries. A primary caries lesion is a lesion that is occurring on a virgin tooth surface. So as opposed to a secondary caries lesion, which is occurring next to a restoration. So you can have an incipient primary lesion, you can have an incipient secondary lesion. So they can go together. The opposite of an incipient lesion would be a cavitated lesion. So you can have a cavitated primary lesion or a cavitated secondary lesion. So it's just talking about whether or not this tooth surface is intact or not. But the Mirror and Explorer most useful for occlusals and the smooth surfaces of the teeth. Sometimes you can get a little bit of information from about the interproximal areas, but it's most useful for the occlusal and smooth surfaces. X-rays, on the other hand, are most helpful for the parts of the teeth that you can't see with a Mirror and Explorer. So, especially the interproximal areas. And when you're talking about radiographic diagnosis of caries lesions, you're usually talking about the bite wing X-ray, because the periapical X-ray, the angulation is different, and so you're getting more enamel superimposed over the lesions, so it's harder to diagnose them that way. But the bite wing radiograph, you're getting the pretty much a straight shot in between the teeth, so it shows up those interproximal lesions really well. So while it works best for interproximal lesions, you can also use it for occlusal lesions. It's just that it's not as helpful for occlusal lesions.
Professor, would a secondary lesion be the same as recurrent lesion?
Right. So a secondary lesion would be the same as recurrent caries. Okay, some things that x-rays aren't going to tell you. X-rays are always going to underestimate the extent of the decay. So whenever you look at a film, you can always guess that the decay is probably about 25% bigger than what you're seeing on the film, just because it's not showing the areas of the tooth that are not as demineralized. So it always underestimates the extent of the lesion. And the x-rays won't tell you if the lesion is cavitated or not. So you're going to have to check with your explorer to see if the lesion is cavitated or not. The way we measure the extent of these lesions is by estimating how far through the enamel or through the dentin the decay goes. So if the decay is in the outer half of the enamel, then we call it an E1 lesion. If it's up to the dentoenamel junction, then we call it an E2 lesion. If it's in the outer third of the dentin, then it would be a D1 lesion. If it's in the middle third of the dentin, it would be a D2 lesion. And if it's in that inner pulpal third of the dentin, then it would be a D3 lesion. So it has nothing to do with the year of the student who's diagnosing it. It's just how far into the dentin it is. Okay. So again, while these are most useful for interproximal lesions, you can use bite wings to check and see if there's occlusal lesions also. Because especially if you have a sealant in the tooth, sometimes it's hard to evaluate the sealant. But if you see a little bit of a shadow underneath the sealant here, then that would be an indication that there's a carious lesion underneath that sealant. Okay, traditionally we kind of diagnosed carious lesions with the idea that we were going to put a filling in them. So we were kind of already thinking of what we were going to do with them before we diagnosed the fillings. So traditionally we only were assessing, how can we fill this lesion up. We weren't really looking at the activity or the causes of the lesions. So lesion detection and assessment of the activity of the lesion are both essential to the diagnosis and treatment decisions. So if you don't understand what's causing the carious lesion, it's going to keep on happening. So we have to be able to detect the lesions early, but we also have to figure out what's causing them. So what is out of balance here? Why is the patient developing a carious lesion? Is it the oral hygiene? Is it the bacteria? Is it that they don't that they don't use fluoride, or do they have too much sugar intake? Do they just not understand what causes decay? Can they not afford just basic, what we would think of just basic everyday stuff? So you have to figure out what's causing the decay, otherwise we're just doomed to getting the decay over again. Okay, so we've talked about the visual inspection for detecting caries. We've talked about radiographs, but there's fiber optic transillumination, there's electric caries monitors, there's fluorescence-based caries monitors. So these will all all help with the detection of caries. So the visual detection method has some advantages. One is that it's been around forever, so we understand it pretty well. It's one of the most commonly used methods for caries detection. It's fairly easy. So it has a high specificity so that you're not going to misdiagnose healthy teeth as unhealthy or as having lesions in them. So you're not going to over-treat the teeth. But there's some disadvantages to it as well. It's subjective. And depending on how tired the clinician is, maybe what would look like a caries lesion to the dentist in the morning doesn't look so much like a caries lesion at 6 o'clock at night. It's subjective. Has low sensitivity, so that means that you're going to miss some of the caries lesions. So some of the small caries lesions, the visual detection method just is going to skip over and misidentify them as healthy. Reproducibility. There's been times when I've had the patient come back the next day for a follow-up, and lesions that I thought I saw the day before, I don't see the second day, or teeth that I thought were healthy the day before. Now I'm looking at a great big caries lesion, and I'm like, man, how did I miss that? So the reproducibility is low, even if you between practitioners. So reproducibility between practitioners. If I look at a lesion, not always does my colleagues see the same lesion when they look at the teeth. In the past, there's just been no rubric for diagnosing teeth visually. So that was, that made it hard for reproducibility as well.
So what do you do if you have two different diagnoses?
So what do you do when you can't decide whether the tooth has a lesion in it or not? So normally caries is a slowly progressing disease. So if you err on the side of being conservative, you're probably going to be safe. And then give your chance to look at it again in a couple of days when you're fresher or something. But normally caries progresses slowly, so treating the teeth conservatively with remineralization is a viable option. So back to Dr. Black. He made a caries classification system back in the early 1900s. It was really focused on restorations. It wasn't so good at describing the characteristics or the extent of the lesion. So mostly, but it's worked. We've been using it for 100 years now, so it's done okay. So let's see. On your computers, you can see this a little bit better. So these are class 1 lesions. Doesn't show up here very well. But class 1 lesions are lesions that occur in the pits or fissures. So you can be in a buccal pit or on the lower first molar, can be in the lingual pit on the maxillary lateral incisor, but the class 1 lesions are pit and fissure lesions. Class 2 lesions are intraproximal lesions in the posterior teeth. So these would be the mesial or the distal lesions on the posterior teeth. Your class 3 lesions are the intraproximal lesions on your anterior teeth. So the same thing, but it's just limited to the anterior teeth. Class 4 lesions are for the anterior teeth, and they just involve the incisal interproximal corner of the tooth. So those would be your class 4 lesions. Your class 5 lesions would be the lesions that occur right around the gingival margin of the tooth. Lots of times people will get a class 5 lesion mixed up with a buccal pit lesion. So, just remember that. So they're both on the buccal, but the buccal pit lesion is in a pit and fissure, so it's a class 1 lesion. Class 5 lesion is a smooth surface lesion along the gingival margin of the tooth. Then class 6 lesions, you can amaze and impress your dentist friends if you know what a class 6 lesion is, because they don't happen very often and they probably don't remember what a class 6 lesion is. But the class 6 lesion is just on the cusp tip of the tooth. So whether it's a canine or a bicuspid, but these lesions occur on the cusp tips of the teeth. Okay. So that would be the GV Black caries classification system. So you might have noticed I didn't say anything about lesion activity. I didn't say anything about lesion extent. All I said was where the lesion occurred. So that's the only thing that the GV Black system will tell you is where is the lesion. It doesn't tell you anything about extent or activity of the lesion. So I said that there's some disadvantages to the visual inspection method of diagnosis for caries. So we need improved sensitivity. We need to be able to diagnose these earlier lesions a little bit more accurately. We need improved reproducibility. I need to be able to diagnose a lesion the same in the morning when I'm fresh as in the evening when I'm tired. We need to think about the activity of the lesion. Where is the lesion in this demineralization, remineralization process? And we should do this more than just on a gut feeling. We should have some evidence to back ourselves up. So there are a couple of caries classification systems that try to address these needs for the visual inspection. One is, oh man, the acronym just jumped out of my head. IC-DOS means something really, really important, but I can't remember what it is right now.
Next slide.
But the ADA, the American Dental Association caries classification system, and the IC-DOS classification system. There we go. International Caries Detection and Assessment System. They try to address some of these discrepancies with the visual method of diagnosing caries. What it is a rubric for diagnosing caries. So the International Caries Detection and Assessment System has a 2-digit identification number. The first digit talks about the surface status of the teeth, so whether or not the tooth has a restoration in it already, or if it's an unrestored tooth. It'll give it a number depending on if it has a sealant or a filling or a crown, or if it's missing. It'll give them that first number. The second number is a measurement of the visual changes in the tooth. So whether it's in the enamel or the dentin, that second digit measures the changes in the tooth. So they attempted to standardize how the teeth are diagnosed. So they said all teeth have to be clean and dry before you do your diagnosis. You have to use a standard explorer or probe when you're using the teeth or using this system. So this standard probe is not the sharp, sticky explorer that we were taught to poke into the teeth when I was a dental student, but it has a more of a rounded end. So it's just to help assess the surface status of the tooth, whether the tooth is intact or starting to break down. And they say that you cannot diagnose teeth without a light. So if you can't see the tooth, you can't do the diagnosis. And they have an e-learning course where they go through the diagnosis system and teach you how to diagnose the teeth. And so this is where the evidence part comes in, because they gave dentists the e-learning course. So they measured the dentist's ability to agree on what was or was not a caries lesion before taking the course and after taking the course. And they were able to show that by using this ICDOS system that they had improved reproducibility and improved calibration between the clinicians. They were also able to show that that dental students were able to learn to diagnose teeth by using this course as well. So it works. So this is what the ICDOS diagnosis system looks like. So it goes from a sound tooth surface all the way over to extensive decay. And so for each stage of the caries, it gives it a number. So a sound healthy tooth would be a 0. A tooth with the first visual changes in the enamel would be a 1, so on and so forth. There's kind of a line between diagnosis 3 and diagnosis 4. That's where the dentin becomes involved in the teeth as well. And then along with the diagnosis, this comes along with restoration recommendations for the teeth as well. So it ties in the treatment with the diagnosis. Okay. So the ICDOS system includes the caries lesion activity assessment, and it's combined with the clinical appearance of the lesion, along with where the lesion is and if it's in an area that's collecting plaque or not. And by combining these two together, they're able to come up with an idea of the activity of the lesion, whether it's progressing or remineralizing. So this would be the lesion activity assessment. So it combines the ICDOS scores over here with the activity scores over here. So if it's a cavitated lesion, it automatically gets an activity score of 4. If it's in a plaque stagnation area, it gets a higher score. If it's a plaque-free area, it gets a lower score. If it's rough, when you drag your Explorer across it, it has a higher score, and so on. So that's how they include the activity in there. So there's other systems out there as well. The NIVOD system is one of them. But back in 2006, the ADA came up with their caries classification system, and it's very similar to the ICDOS system, except they included radiographs within their system. So it makes it a little bit more complete, and they made it a little bit less. So instead of 6 different diagnoses for the teeth, they came up with 4. So whereas the ICDOS has scores of 0 through 6, the ADA caries classification has scores of just 4 different categories. So sound, initial, moderate, and advanced. Any question?
Which one do you want us to know?
I want you to know both of them.
Okay.
Because we haven't decided on clinic which way to go yet.
Okay.
So you should be able to use them both.
Got it.
Okay. But you'll notice the ADA caries classification system includes the radiographs on the bottom. So if your lesion if you don't have a radiographic lesion, then it's a sound tooth. So that would be under your diagnosis of sound. For your radiographic lesions from E1 to D1, those would be classified as initial, so on and so forth. Okay. Okay, so far we haven't found a better way to diagnose caries than the visual inspection of the teeth, the Mirror and Explorer. So it's still kind of our gold standard, what we use. Probably the best way to diagnose caries would be to take the tooth, cut it in half, and put it under a microscopic slide. And that would be the most accurate way. Might have a little bit of pushback from the patients, but that would probably be the most accurate way. But the visual inspection is the best option that we have right now. So, and you're not going to see a lot of the interproximal lesions with the visual inspection. So you need another adjunct method for diagnosing X-rays. So we've talked about radiographs, how they're really helpful for detecting proximal lesions. It can also show up the occlusal lesions sometimes. But the radiographic method also has its disadvantages in that it's radiation. So it's not a lot of radiation, and we're doing the films that we use today are a lot faster than the films I used when I was in dental school. We use lead aprons to protect the patient, so we're minimizing the amount of radiation that we expose the patient to. It's still something that we want to be concerned about. So we only want to take the X-rays as often as we need to justify the benefit of the X-rays. So again, the radiographs really don't tell us very much about whether or not the lesion is cavitated or not. It probably underestimates the amount of decay that you're seeing. But yeah, it's best used as an adjunct to your visual method. You're still going to have to look at the teeth. There's some new developments in radiography. So there's a digital subtraction radiography, and what they do is they take two radiographs from two different times and superimpose them over each other, and they're able to show the progression or regression of the lesion, whether it's an endodontic lesion or a carious lesion. For those of you who've taken X-rays and tried to get the exact same angle the second time as you got the first time, you can understand that this might be a little bit tricky. But with some of the CT machines where they can get these angles just perfect every time, then it shows a little bit of promise. But it's a lot of work to and probably more radiation than what we want to expose the patient to. Okay, I talked about fiber optic transillumination. This is where you just shine a fiber optic light through the tooth, and if there's a lesion in there, it will show up as a shadow. So you can see here where this fiber optic light is shining through the tooth, and it's blocked by the carious lesion, so the light is not transmitting through. So that'd be a carious lesion here. Obviously, the light won't shine through an amalgam either, but probably didn't need the light to tell you that there was an amalgam there. There are electric. Let's see. So advantages is that it's easy, portable to use. You can even use the fiber optic on the handpiece to shine through there if you want. Disadvantages is it's still subjective. It's not quantitative. It's helpful when you when you're looking at a tooth visually and you're like not sure if there's a lesion there or not, this can help to confirm it. But other than that, there's really no advantages over conventional methods. It's a nice adjunct if you want to confirm something. Okay, electronic caries monitors. So these always make me cringe a little bit because when I was growing up, my little brother liked to make little shock boxes. So he'd put a little transducer, wrap it in an aluminum foil, put a red shiny bow around it, and then give it to you. And then there would be a little mercury switch inside there. When you twisted it a little bit, it would shock you. So anytime I see where they're using an alternating current to run through my tooth, it just makes me cringe a little bit because I had that little brother. Anyway, but it doesn't hurt. That's what they tell me. The electronic caries monitor doesn't hurt. It just measures the resistance of the current through the tooth. So carious teeth will have a different amount of resistance than non-carious teeth will. And it's a quantifiable amount, so you can measure the progression of the lesion over time. Again, they have some advantages. They're quantitative, so you have a number that you can measure. They have higher sensitivity values than conventional methods, so you're going to be able to detect small carious lesions. But reliability is kind of fair. Probably depends on how clean the tooth is, how much saliva is on the tooth. Those will all make a difference. Specificity values are low, which means that it's going to identify some healthy teeth as carious. So you're going to overdiagnose some teeth. So that would be definitely a downside. Doesn't tell us anything about lesion activity. It's hard to use on proximal surfaces. So again, it's useful as an adjunct, but probably not as a primary diagnosis method. Okay, the fluorescence-based methods for diagnosing teeth. So the carious lesion changes the way the tooth fluoresces. So if you shine a light on the tooth reflects that light back, and depending on the wavelength that it reflects back, the machine is able to quantify that and make a diagnosis. So a mineral loss causes a decrease in fluorescence, and this reduction is analyzed and put into a number. They're getting smaller. So you went from that great big one that I showed you on the previous slide to this little tiny one here. But the Diagnodent has been shown to be very, very helpful. Still not as useful for interproximal caries, but still very helpful. The advantages with the fluorescence-based methods is that you get very good reproducibility. It's quantifiable, so you can monitor the progression of the initial lesions. It says no radiation exposure to the patient, so no dangerous radiation anyway. There is light radiation, but yes.
I have a question. I've never seen these before. Are these common?
No, they're expensive. So they're expensive, and like I said, they're used as adjuncts. And so they're they're not used very often. But especially the Diagnodent, you'll find in more offices than some of the other methods. But yeah, the visual method is still the gold standard. So these are more of an adjunct. The disadvantages of these, especially when they first came out and people didn't understand that they were diagnosing smaller and smaller lesions, they tend to have a high sensitivity and a low specificity. So they're going to diagnose the very small lesions, and then they're going to misdiagnose some of the healthy teeth as a carious tooth. So the problem was is that dentists were still using these very sensitive diagnosis methods but using still the old school, if it's a cavity, fill it. So they're drilling out these very small lesions, and people were understandably upset that all of a sudden they were getting more cavities than they were before. But it was just a misunderstanding of how these methods are diagnosing smaller and smaller lesions. And there's definitely no activity assessment with these. Okay, so treatment decisions, you have to have a clean and dry tooth. Try to use some sort of reproducible method for diagnosing your teeth, and then your teeth can be, your treatment can come from there. So when you're deciding how to treat your teeth, first of all, you got to determine is the lesion active or inactive. And if it's inactive, then there's probably no treatment needed, unless you're treating it to restore aesthetics or something like that. But an inactive lesion doesn't need to be treated from a disease standpoint. For your active caries lesions, for the higher scores, you're going to need to do some sort of, where there's already cavitation involved, you're going to have to do some sort of operative treatment. For your lower scores, where the decay has not cavitated, the lesion has not cavitated, then you can do some sort of non-operative treatment. So it kind of goes against the grain for if you've been taught that a cavity equals a filling, but now we're thinking as long as the caries lesion is inactive or remineralized, then you don't need to put a filling there unless you're trying to make it more aesthetic. But the filling is not going to do anything as far as the disease itself is concerned. Okay? If you needed to rebuild it for aesthetics or function, well, then you could put a restoration in there. But when you're just talking strictly about the disease, there's no restoration needed. Okay, so to summarize, traditionally we were thinking more about not so much about caries management, but more about restoring the holes in the teeth. And now we're thinking more about managing the disease, so understanding what's causing the disease, and then figuring out how to either reverse it or stop it. Okay? So caries diagnosis, now we need to be able to do it this way, we need to diagnose the caries lesion earlier so that we can stop it before it becomes so big that we have to address it surgically. And then having some reproducible way, so some sort of rubric when we identify our teeth is really important. Okay. So there's other methods out there, and there's always more methods being developed. Just always understand what you're using to diagnose the disease so that you don't end up over-treating the teeth. You have to understand the tool you're using, how sensitive is it, how specific is it diagnosing small lesions, is it misdiagnosing healthy teeth as caries. So once you understand the instrument that you're using, then you can make an informed decision with it. Okay, bite wings, radiographs are indispensable. Yeah. Next time there'll be a quiz on the readings. So in your module, yes.
Is it the readings and this lecture?
Just the readings.
Okay.
So I just want you to understand a little bit of what the readings should have something to do with the lecture, I hope, with next week's lecture. I just want you to have a little bit of understanding before we get to it. And hopefully we'll start on time so we won't run late.
Is there a quiz every Monday? And then do you have a schedule posted anywhere? As far as
Under Canvas, there's a schedule. So just under the modules.
the quizzes will be based off of the previous lecture and the lecture that's going to be on?
No, just the readings.
Just know that there's a quiz every Monday. That's it. Bye.